Welcome to the Rocky Mountain MS Center's Empower webinar series. This series is designed to give people with MS information to empower them to make the best choices for their lifelong brain health. I would like to thank the pharmaceutical companies who have provided support for this program. Thank you to Genentech, Novartis, and Sanofi Genzyme. Today, August 30th, 2021, we will be giving an update on COVID-19, variants, vaccines, and MS. This presentation features Dr. Enrique Alvarez. Dr. Alvarez is the Vice Chair for Clinical Research at the Rocky Mountain MS Center at the University of Colorado. He is a graduate of the Medical Scientist Training Program at the University of Colorado, Denver, and completed his neurology residency and neuroimmunology fellowship at Washington University in St. Louis. He joined the Rocky Mountain MS Center at University of Colorado in 2013. This webinar features a lot of important information. If you missed something on a slide or want to hear it again, we will be archiving this webinar on our website, www.mscenter.org, so you can replay it at any time. We'll reserve time at the end to answer questions from the audience. You can submit questions at any time by typing them into the chat window on your screen. We will answer as many questions as time allows. Today's presentation is for informational purposes only. All decisions regarding MS treatment and medications should be discussed with your neurologist. And with that, I'll turn it over to Dr. Alvarez.
Thanks, Kelsey. Let me start sharing my screen. Perfect. So welcome everybody to this webinar. I think we're getting a ton of questions around boosters and things like this, and we'll talk a little bit about that, I think, today, and try to provide a little bit of guidance. I can tell you that there's not a lot of consensus as to what to say about that. So that's why I'll give you our opinion and kind of why we think this, and kind of go from there a little bit. Before we start talking about that, just to kind of understand where we're at right now. So as you look at numbers in the world, we're kind of facing maybe our fifth wave at this point. As far as kind of on a global scale, you're seeing that almost 10 deaths a day, or 10,000 deaths a day. And that this peak is almost as big as sort of our, probably our second largest peak, getting close to at least some of those numbers. As we look at it in the US, it's definitely been our second biggest peak out of the 5 that we've had. You can see that in the US, we're starting to get around 1,200, 1,300 deaths per day, which is easy to be said, but it's a big number. And as far as hospitalizations, almost 100,000 new hospitalizations a day. So definitely, these are big numbers, and we're starting to see that in our hospital. I didn't put in numbers for our hospital, but we're clearly in our second largest peak at UCH, and we finally left clinical divert, but most of that's just been because they've stopped canceling some surgeries or they started to cancel some surgeries so that they could get free up some beds to get people into the hospital, which is kind of a sad way to kind of create space. If we look at kind of the predictive models that I've presented in the past, we can see that we're really not sure where we're going. This gray zone, as far as cases, you can see it could go down pretty fast, it could go up really fast, and it's really hard to kind of know. As far as ICU, kind of following that likewise. And so we're not quite sure where this wave is going to head up. We stabilize for a day or two and then it spikes up. We stabilize for a day or two and then it kind of spikes up. And so just being aware of that. I think one of the things to realize is that the vast majority of people here have not been vaccinated. And so it's an important concept around that. When we look at the map of where the majority of cases are coming from, we can see that besides making any political type statements, that it kind of matches political mapping some, although definitely we see areas that are a little bit bluer that have high numbers of cases as well. But it's understanding that some of these counties may be, are a little bit more mixed and that kind of stuff. I think what's important to kind of look at this is trying to understand sort of the vaccination rates. And so if you look at, for example, here's the top 5 states as far as number of cases and the bottom 5 states as far as number of cases. You can see here the number of cases per 100,000 people. That US is sort of averaging about 47, and that low end is about 20, but close to a 90 to 100 in those top 5 states. And I think the one thing that you can kind of see pretty easily is just the vaccination rate. Those states that have the largest number of cases have the lowest rates of vaccination, and those states that have done better have have much higher rates of vaccination. So this shows, I think, that this issue, or maybe one of the questions around does vaccines work, and the answer appears to be very much yes. So where are we at as far as vaccinations go? We can see that the people who are at highest risk have taken this a little bit more seriously, and that about 82% of those 65 and older have been vaccinated fully. So this is great news. As you start to look at 18 and up, we would like to get at least into the 70 to 80% range, and we're still falling behind that, although these numbers are coming up a little bit. And then, obviously we would love to be able to get kids vaccinated, but we're still limited in being able to vaccinate those 12 and under, or sorry, 11 and under. And so that's pulling down some of these numbers. But a lot of times you'll hear different numbers, and understand sometimes that people use, for example, the number for having received 1 dose of 18 and higher, or sometimes they'll use 12 and higher because those are the ones that can be vaccinated. Or sometimes people are using all ages. Sometimes they'll talk about at least 1 dose versus fully vaccinated. And so this is why you can see anywhere from a 50% to a 90% as far as the numbers that are being circulated as to where we're at for vaccination. This is a series that I got. It was a nice animation that I got from the New York Times, and it runs through a concept around why are we still seeing cases even in vaccinated people, and what's the big advantage of getting vaccinated. And so just to kind of run through this animation, I took snippets of this, and again, this comes from the New York Times. Want to give them full credit for developing this. I think, to me, I like seeing things visually, and this really helps me a lot. So if you imagine a population has a really high rate of vaccination and a group that's really low rate of vaccination, vaccinated being green and sort of brown tan color for not vaccinated. So you got these 2 groups that are different as far as the vaccination rates. And in highly immunized groups, the vaccine protects most of those vaccinated against becoming infected with the Delta variant. And again, it doesn't have to be the Delta variant. It could be any other variant or coronavirus by itself. But you do get some breakthrough infections. So even in those that are vaccinated, you'll see some infection in those. Most of these will be mild or symptomatic, so most of these patients do okay. Some of the people might have had previously COVID as well. But the infections around the vaccinated, so yeah, you see a lot more people in the vaccinated group here having infections than those without, just because this was a larger group of people in that group. When you look at the unvaccinated group, or this population that's mostly unvaccinated, most of the infections will happen against those unvaccinated. But in this case, notice that the vast majority of infections happen in those who were not vaccinated. Because few have had the vaccine, the infections tend to be more severe. And so these in the hospital here are in darker blue color. And when you look at the number of hospitalizations, you can see that the larger majority of them tend to be against those that were not vaccinated. And you can see how these differences kind of come out. And those that have more severe illness particularly will come from the group, from the population that haven't been vaccinated much. So I think this helps, I think, paint the picture to kind of say the vaccine doesn't work on everybody, that you still have some breakthrough disease that we're still seeing even in areas with a lot of vaccine, that the hospitals are filling up. But that it's important to kind of recognize that in those areas where the vaccines are low, those people are getting much more severely ill. And so not only are the hospitals getting full, but it's especially those IC units that are full. And that's what we're seeing in most of the US right now, is a lot of places with ICUs being full. One of the distinctions I want to talk about a little bit is when we start to look at naming. So COVID-19 is the infection, the virus itself is SARS-CoV-2. And when we start to talk about antibodies to these infections, let's talk a little bit about what the virus looks like. So here's a kind of the virus. You have the RNA for this virus. And in this situation here, you can see the spike protein, the vaccine, you're making basically spike protein. So you can develop antibodies to this. And that's important because if you develop antibodies to the spike protein, or you get the treatment of antibodies to the virus, what that allows it to do is prevent the virus then from attaching to cells. Seeing here, it would interfere with this so that it can't bind to this ACE2 receptor. And some people may recognize the ACE receptor because ACE inhibitors, which is a type of blood pressure medicine, affects this pathway, and this is what is recognized by a virus. So this is in blood vessels and heart and things like this. And it might be a little bit why this virus is causing a little bit more issues, is because it's directly affecting the heart and blood vessels, and you get blood clots and things like that. When you also have the other protein that I'm going to highlight besides sort of that in the membrane and the envelope are the nuclear capsid proteins. And so I bring this up because when you're testing whether or not you've reacted to the virus or you're protected from the virus, there's two main antibody sources that we will see. One is the nucleocapsid and one is the spike protein. Nucleocapsid antibodies, you tend to only form then from a natural infection, from actually getting the virus. Versus those that are against the spike protein, you can get from either having been infected or because of the vaccines, because the vaccines are again making that spike protein. Within that spike protein, this RBD or receptor binding domain is the part where the receptor actually binds to. And so this is where the assay really is helpful, because then it can kind of give you a sense about being protective. If you block this area out, and then they can't bind to their receptor. So depending on what you're trying to see, hey, I've been infected, then nucleocapsid is the antibody you want to check for. If you want to check and see, hey, am I responding to the vaccine? Am I protected? Those kinds of things, then you want to look at the spike protein. Again, most of the assays don't make the guarantee that, hey, if you have a certain level, now you're protected, but the higher levels of antibodies against the spike protein, the higher the chance that you're going to be protected against the SARS-CoV-2 virus. And we'll talk a little bit more about this as we look at some of the testing. So this is a busy slide, but there's a lot of talk about variants. And, we've changed the name of these. We used to, talk about the alpha variant. So there was the original virus, and then we started talking about the alpha variant. And this was a lot of times being called the UK variant, the B117 variant. And so to try and just change it and not necessarily, oh, United Kingdom is to blame for this variant or things like this, they started calling these variants alpha, beta, delta, gamma, and such. And so you can see that, I highlighted delta because this is the main one we're concerned about. And you can see that a lot of these kind of fairly similar as far as what they kind of have as far as why they're variants of concern, as the terms used by the CDC, for example. So let's break this down a little bit, and I'm going to concentrate mostly on the Delta. I just wanted to put these other ones in here for people if they're using these as a resource, for example. And this came from the CDC website. Just kind of copy and pasted some different areas of information that I thought were maybe a little bit more helpful. So with a lot of these variants, one of the things that they changed was how much of the virus you make, so that when you sneeze, you release more virus, for example. If you release more virus, it makes it a little bit easier for somebody at the other end to catch it. And so that's why with these variants, you're seeing sort of this 50% increase in transmission. There's been a lot of discussion about whether these cause more disease, more severe disease, and sometimes simply by getting more virus, it doesn't let you react to the virus as well before the virus can take hold. So just passing on more virus can make the disease more a stronger disease, more severe disease. And so it's hard to kind of separate these things out, but with this increased transmission, we can see that these diseases appear to be more severe as well. So these do have different mutations. You can see a lot of these different types of variability. The Delta one was the one that we kind of think started or was first at least identified in India. And so these have decreased ability these are antibodies that are made in test tubes to treat COVID. And because the mutations affect where these antibodies bind, these treatments aren't as effective as they were against the main virus or kind of the original SARS-CoV-2. But there are other emergency use approved type monoclonal antibodies that are available that can neutralize this antibody. Because these are different, so if you take blood, this convalescent plasma, or people after vaccines, again, these vaccines are against a different type of virus, the non-variant one, then you're not going to be able to neutralize these antibodies as well either. So this is where it gets tricky. Some of our treatments have kind of gone past their usefulness a little bit because of these mutations. And so these are kind of the main ones you often heard. In the early days, we were talking about the mutants that were variants that had happened in the UK and South Africa, India, Japan, and Brazil. But there's a lot of other ones that also have kind of come up that maybe we've not heard as much. So Eta, Iota, Kappa, Lambda, other ones that haven't been named yet. Lambda is a big one sort of in South America. It was not listed as a variant of interest by the CDC, but it is by the World Health Organization. And so as we start to look at these, again, just knowing that these might be the next ones to kind of come to the US, I guess. So just a few things to kind of consider is that mutations happen as the virus replicates or as it multiplies and it grows. And so one of the things to think about is that the more widespread the virus is, the more it's circulating and multiplying and people are getting sick from it, the higher the chances of mutation. And so it's not too hard to fathom then that most of the mutations that we saw were actually identified in October and December of 2020, because that was that big last wave that we had. So as the virus was kind of going around, then it was mutating, and these variants that could spread more rapidly then took a hold and started to spread more rapidly and became kind of the big infection. So as we start to think about this, if we can control these next infections, these next waves, it just makes it that much more likely that we can actually stop the disease from mutating, becoming different. If we continue to let these waves and spikes of cases continue to happen, pretty soon we're going to be on the Zeta variant, then, who knows what's going to happen with those. So as we look at the Delta variant, just to provide some sense for it. So as we look at the vaccine effectiveness, most of the vaccines that we saw against the original strains, we would say, were 90 to 95% effective. And yes, against the Delta variant, it looks like against symptomatic infections, we're down to about 85%. So maybe it doesn't quite work as well against the Delta variant, but 85% chance of preventing a symptomatic infection is pretty damn good. And again, more important than that is that it's still 90 to 95% effective at preventing hospitalization. And if we start to look at ICU, intubation, death, it's not 100%, but it's pretty damn close to this number. And again, this is the part that we worry about being able to care with people, right? I mean, if you end up with chills and body aches for a week or two, I can deal with that. We got lots of chicken soup, but we don't have a lot of the bimolizumabs and other mumababs that we might need to treat this, and especially if maybe those aren't quite as effective. So again, the vaccines that we have for this group of ICU and intubation are really good vaccines still. All right, so I've heard a lot of myths around vaccines, and so I'm going to spend a little bit of time kind of going through this and trying to convince that the vaccines are totally worth it, and we can kind of go from there. And so the mRNA, so one of the biggest ones that I hear is the mRNA vaccines are new and have very little data to support their use. So this is one of those where it's a yes and a no. Yes, they're new types of vaccines. This is the first type of messenger or mRNA vaccine on the market, but it's not really that new of technology. This technology has really been started to get developed in the 1980s. There's reports from 1995, papers actually written showing that mRNA vaccines could produce antibodies and cellular or T-cell immunity against different pathogens. And so, this is starting to get into that 25, 26 years of experience with it. And we got to think about a lot of the drugs that we're using in MS were not around in the 1990s. As far as do we have a lot of data to support their use? Well, worldwide, there's been 5.22 billion doses as of today given. In the United States alone, 369 million doses have been given. And the Pfizer vaccine was actually fully approved now on the 23rd. So last week, Monday. And so I think we have about as much data. Consider that for most of the MS drugs, they're getting approved on maybe trials that include 5,000 people. So if you look at 5,000 people compared to 5 billion people, that's a couple of orders of magnitude larger than the data that we would have on most of the drugs that we use for MS. So I would argue that we have a ton of data to support the use of vaccines in MS patients. Some of these are kind of hard that we have to kind of go through it, but they contain microchips. So no, if you look at the inside diameter of the needle, it's about 0.15 millimeters. The dimensions of the smallest chip that's out there that actually could potentially have a GPS unit that I could find was at least pretty much 5 times that, or 15 times that, sorry. So there's no way that this chip would actually make it through the needle. 5 millimeters is about 0.5 centimeter, so you could easily see this. So if somebody's injecting you with any of this stuff, you'd be able to see it on the vaccine stuff if you're concerned about it. And the reality is that we all carry chips with GPS on them in our cell phones. And if somebody wanted to listen to us, not sure they would have to inject us with us to get that information. So no, I don't think they contain microchips. As far as COVID vaccine will alter my DNA, I've heard this from a lot of smart people as well. And the reality is, no, this cannot happen. When you look at DNA in our cells, the way this works in humans is that this then gets made into RNA, messenger RNA here, and then that RNA can get made into proteins. Notice that the arrows don't go backwards. So you cannot make it from protein to RNA or RNA to DNA. So this will not change your DNA at all or alter yourself at all. So this is strictly starting at this point. You can make protein, and the one protein here is then that nucleocapsid protein. So it doesn't make the whole virus, it only makes one protein, so you cannot get COVID from it. I'm not sure where this one came from, so I couldn't provide much more detail, but it will cause you to be magnetic. There's no metal in the vaccine, so I'm not sure how you would get to be magnetic from it. Spend a few minutes on, can you get sick from the vaccine? Probably, but you will not get COVID. So what do I mean by that? Is that most people do react to the vaccine and can develop arm soreness, fatigue, fevers, chills. But the vaccine, again, only has that ability to make that spike protein. So you cannot make the whole virus. So you're not going to be able to make virus from itself. So you can't spread it to other people or things like this. Now, it is possible that because of those fevers and chills, you might develop pseudo relapses, old symptoms kind of coming back, but not real relapses in the sense of getting new inflammation in the brain and the spinal cord. And so it's, in this case, a lot of chicken soup. Tylenol ibuprofen works really well against the fevers and chills from this vaccine. And so that would be kind of the treatment for it. And then as soon as the fevers and chills get better, then kind of coming back down to being back to your normal self. The COVID vaccine will make you sterile. Really don't quite get this one. So the answer is definitely no. This has been looked at extensively. There was a paper published in the New England Journal of Medicine back in June that looked at almost 4,000 pregnancies, with about 14% of them resulting in miscarriages. The issue is that really about 15 to 20% of pregnancies normally end up in a miscarriage. So this was well within the range of what we would expect of miscarriages to be ending up in a study like this. So it didn't increase any of these kinds of issues or anything else like this. That ACE2 receptor is not present in any particular tissue of baby besides sort of, again, heart and blood vessels, kind of like in adults and things like this. And so, for reasons as to why it would make you sterile, it's not present in sort of ovaries or other things like this. So if the concern is more about sterility versus sort of miscarriages, that part of it I really don't get, because it does not affect any of those types of tissues. They don't have the right receptor for the virus. So those are some of the myths around the vaccines, and we can get to other ones if people have them. But I think, this big question that we're getting a ton: should I get a booster? And the answer is a definite yes. If I have a recommendation other than this that I would emphasize more, is to make sure that you don't stop MS treatments if we've been recommending that, but everybody should be getting vaccinated and getting a booster. Right now, where are we at? Right now, it is recommended for those with moderately or severely compromised immune systems. So this is looking at most of our patients, outside of maybe those patients who are on interferons or Copaxone, maybe Aubagio or teriflunomide. But outside of that, I would recommend almost all the other patients to get immunized. Timing. Well, if you're on Gilenya or Tecfidera, it's hard to kind of talk about timing because you take those medicines on a daily basis. But as you start to kind of talk about infusions, I think the main thing to think about is not trying to do a booster or an injection the same day as you're getting an infusion. Because if you should have a reaction, it's important to realize that you want to know what you reacted to. And if you're getting two different treatments at once, it's hard to separate that. So on the case of Tisabri, I would try and do it sort of in between those infusions. So 2 weeks before, 2 weeks after an infusion, since that infusion is every 4 weeks. For rituximab and ocrelizumab, which are infusions every 6 months, we would like to wait, somewhere around 4 weeks before or after those infusions. We're seeing a lot of differences in recommendations around this. National MS Society put in a recommendation for waiting 12 weeks after the infusion and then 4 weeks before your next infusion. So that gives you a window of about 2 months. With a booster and having had the flexibility that you already had the other vaccines, maybe that makes a little bit more sense and less urgent to kind of try and get the booster. given the fact that we're in this huge wave and just trying to kind of build up that immunity, maybe saying, hey, I just want to get the booster, not have as big of a window. I think all those things are fine. Is there a lot of data for this? There absolutely isn't much data around this. There's issues around a lot of theoretical thought of letting B cells come back. Well, your B cells don't come back in between the every 6 weeks for most people. So this idea of creating a window probably doesn't make a lot of sense. We had a couple of paper submissions to us. One I'm going to push off a little bit until I show a little bit of our own data as well, because it looks very similar to it. The other one was around sort of different types of B cells and kind of when they come back and things like this. And the reality is that we just don't see B cells in the window of every 6 months. Our hospital, just to make it very clear, also put in a recommendation of not doing a booster during the 6 months of having had rituximab. Again, recognize that there's nothing magic at 6 months. Most people's B cells don't come back for 9 months. That's the average. Some people's B cells may not come back for 2 years, and I'm definitely not going to recommend people waiting 2 years before they would get a booster without any treatment for their MS. And so trying to follow B cells before your infusion, I don't think makes a ton of sense. And that has to do, again, with some of our own data as well. One of the concepts is that some people just don't respond to vaccines. For some of you, you've already heard me talk about sort of this example. I have had 12 shots for hepatitis B because this is the one I just didn't respond to. So I got lots of extra doses for this. And this one, in this case, this was actually in alcoholics with liver disease. And so you had the standard dose, and then you had sort of this double dose with an extra dose in there. I just got the double dose without the extra dose. But you could see that the difference in antibodies made a huge difference with this extra dose. So the moral of the story is we can convert pretty much everybody. It's just trying to understand who do we need to do this higher doses on and things like this. And right now we're a little bit more limited and still trying to figure out what we can do and can't do, given the fact that we just got access to the boosters really a week ago when the Pfizer vaccine really got approved, as far as being able to consider some of these possibilities. Let me talk a little bit about immunology. So when the virus, in this case, the SARS-CoV-2 virus, comes and says it infects cells, and in this case, these are lung cells with these little hairs attached to them. It could be heart cells or things like this. These are going to put signals to natural killer cells to try and help fight it. So this is one arm of the military that the immune system uses to try and attack that. These cells then would make other new viruses. These cells that are infected are going to give warning to other cells of try and come back and get me. Macrophages might come and be able to eat some of these viruses. So that's another kind of arm of the immune system. You also then have B cells and T cells. And so B cells and the people that were talking about different types of B cells, these run sort of from naive B cells that are not selected to fight any type of infections to mature B cells that are really good at fighting a specific type of bug. These can then become plasma cells, which are the cells that make antibodies. So when you take a B cell depleting therapy, rituximab, ocrelizumab, ofatumumab, these cells are knocked out. You still have plasma cells. So if you got to this point, you can make those antibodies. But again, if you don't have B cells, you can't make those antibodies as well. Now, the reality is that most of these antibodies and mostly are affecting these cells in the bloodstream, meaning that there's still B cells in things like lymph nodes, the spleen, and other things like this. So you can still help fight these viruses. And that's part of the reason why we see a lot of MS patients with no B cells in their blood who are still able to fight COVID, just maybe not quite as well. Additionally, T cells form another important part of this immune response, and these cells can then attack the virus itself. And these cells, B cells and T cells, can talk to each other. B cells often present antigens so that it helps the T cells go fight those viruses and things like that. So it's a complicated system of cells that talk to each other to try and help fight that immune response. I bring this up because when we look at antibodies against a virus, we're measuring mostly this B cell response to the plasma cells that attack the virus. And often we don't look at T cells. And at least looking at some of the preliminary data, these T cell responses look like they're important. So here's a little bit of data. There was a reference from the Israeli group or Israeli study. This is very much in line. This is from our clinic, however, and this is looking at antibodies to the spike protein, excuse me. And so this is at week 1. I'll concentrate on this panel. So this is after the first vaccine, this is after the second dose of the vaccine. And you can see that after the second dose of vaccine, even after the first one, that the vast majority of control patients had antibodies. 1 here marks where we think those antibody levels would be protective. Those levels jumped up after the second dose with everybody going above 1. And you can see that none of the patients on B-cell depleting therapies jumped up over 1. And only 2. So our numbers were 2 out of 10 or 20%. The Israeli group was 23%. So I think that the main issue is less that people on these drugs are going to react differently to the vaccine or things like this. It's that they just won't react and form these antibodies as well. But again, if we go back, this T cell response is intact and should still occur. And this is one of the things that was seen for natural immunity. So this is data from New York University, NYU, and showing that people, this is specifically about making antibodies. They had different types of ability to look at antibody formation and from natural infections. So this is not from vaccine data. Again, these numbers are fairly small, but you can see that for those on Ocrevus, for example, versus those that were not on Ocrevus, that these numbers are much larger than these. So again, the ability to form antibodies is much better if you're not on Ocrevus. And this makes sense. And it's, again, what we've seen, what the Israeli group has seen. If we look at T cell responses, these appear to be fairly similar whether you got Ocrevus or not Ocrevus. So there were no differences between these two groups, different types of assays again, but again, 39%, 39%, 86, 67. I mean, again, very, very similar in how you look at these. And so to some extent, the T cell responses against natural infection appear to be really pretty good. Here you can see differences against this group in green in the first panel, and that's just groups that did not get the COVID vaccine, so they're not going to develop those immune responses. Again, here for those that did not get COVID, just the responses weren't that good. So the T cell responses appear to be pretty good. That's probably what's protecting most of our patients anyway. We know that patients without antibodies altogether, patients who have genetic mutations that don't let them make antibodies, can survive COVID, and this is a case report of 2 of these patients. So we can understand that the immune response is going to help protect us. There's other risks that push us. We've spent a lot of time in prior webinars talking about this. So I'm going to go through this really pretty fast. And that's for risk of MS patients and which MS patients should get prioritized, right? And right now there's tons of vaccine. I just confirmed this with sort of a meeting I had a couple hours ago. Right now there's no issue as far as number of vaccine doses that we have available for boosters. So to some extent, I'm not too particularly worried about trying to strategize who should be getting these and just saying people should just get vaccine. But age is a big important factor, especially if you're over 70, males a little bit higher. Heart disease, especially if you have heart failure more than blood pressure issues. COPD, much more so than asthma, for example, as far as respiratory diseases. If you have uncontrolled diseases such as diabetes, renal failure, liver failure, cancer that's not responding to treatment, things like that. by itself, MS doesn't appear to be a big issue. And the one exception are those patients on B-cell therapies. Disability level is probably our biggest predictor in MS patients, much more so than probably even age or other comorbidities. So again, this is kind of the data that was presented. This is from the Italian data. This is from kind of a larger consortium of people that include some of that Italian data. But again, you can see that males almost twice the risk of females as you increase the age, maybe threefold higher compared to those that are under the age of 50. If you have progressive versus relapsing type of MS, and again, most of these patients are going to be more disabled, you can see that EDSS is a disability measure, much higher level of disability of infection risk of having to get hospitalized in this case, compared to if your EDSS is below 6. 6 is needing a cane. So you can see, above and below that. If you look at patients on B-cell therapies, as far as hospitalization compared to ICU, compared to ventilation, that their risk continues to increase. We don't see that with death. And that might have to do because as the disease changes from being mostly fighting the virus to now your immune system is getting out of whack, B-cell therapies might help control this response some. Again, very theoretical still. I'll put a plug in. We're still trying to study more of this, and we're gearing up to look at a booster study. One of the things that we're waiting on is to get some special tubes to actually do a little bit better job of looking at T-cell responses. Here's a number to contact if you're interested and are available for blood draws. We're getting blood draws at a number of time points, including before the booster and then at various points after the booster. And the idea is to look at B and T-cell responses in a couple of different ways, each again, to try and see what effects we can see. So as we start to look at this, what should we do? What are the guidelines? So with B-cell depleting therapies, B-cell responses to vaccine are not great, but these appear to be much better after a third dose, a booster, or natural infection. And so not part of those graphs, but in kind of anecdotal experience, people who have had 3 exposures or more have all pretty much all converted to making antibodies. And we probably now have 2 or 3 people that have gotten boosters that we've been able to look at that, and a couple of people who had COVID and then got the vaccines. And again, we've been able to see that even on B-cell therapies that their responses look much better than just the 20%. The T-cell responses to the natural infection appear to be better. And again, they don't protect everybody. There's some breakthrough disease, but it protects against bad disease. So because of that, we recommend getting the vaccines. Some people have gotten to calling these third doses versus boosters. If you think about it, and most of the vaccines that you get as a kid, for those with kids, and remember taking your kids in for all these extra vaccines when they're in that first year of life, a lot of times most of the series of vaccines have 3 doses. I think it was good to kind of break it up, because if we had to get a vaccine approved that had 3 doses, it would have taken a really long time to get the vaccines approved. But you're kind of seeing really this transition of calling it from a booster to a third dose. Be careful in the sense of, hey, we're in the middle of another spike in cases. So this is the point about knowing who you're hanging out with. And if you're not sure who you're hanging out with in the sense of how trustworthy they are, that's a good time to kind of wear a mask. But it's important not to get too afraid of leaving the house. And I'm still going to recommend continuing to do well, eat right, exercise, meeting with friends and things like this. Again, people you trust to be able to do that. And so I think with that's kind of the material I had. Kelsey, if you've been monitoring the chat box and everything else that's been sent to us, if you want to let me know what other questions have come in.
Yeah, we've had quite a few questions. Thank you so much for your presentation so far. I did want to let folks know you can continue to submit questions. And just remind folks, we cannot answer specific medical advice questions. So I'm going to be grouping and kind of generalizing some of the questions that have been submitted. We haven't had a lot, so thank you guys. Um, I'm going to go back to, I know you talked a little bit about the spike protein and the testing, but we did have a lot of questions submitted about that. So I'm just wondering if you can speak a little more on whether or not the testing that we currently do, if someone goes to say donate blood or something and it looks for the antibodies and they're showing negative, do we have a better way of measuring if folks on B cell depleting meds are making antibodies? Do you anticipate us having another, or is it just get the booster whether or not you've made the antibodies?
Yeah, so I think for the most part, as far as getting the third dose, I would just get the booster and get the third dose, even if you have enough antibodies. People who have had COVID and have gotten the vaccine, I would still get the third dose. I think that that's really sort of a complete vaccine course at this point, and this idea of maybe not calling it a booster makes a lot of sense, given that most vaccine courses are again 3 doses. Part of the issue is if you do make antibodies, how often are we going to have to check them? Because we know that these antibodies keep decreasing over time. So do we check them now? Do we check them in 6 months? Do we do another year? Then do we do the booster, that kind of stuff? And so I think what we're going to end up doing is basically doing boosters pretty much every year. Or something along those lines, kind of like we do with the flu. Just depends on the strains that are out there and things like this. So trying to kind of have a sense for that, I think, becomes important for kind of knowing what to do. If you are negative, then we can kind of keep giving you vaccine. The challenge a little bit is at this point, we don't know, like, can we give you two, we can't quite give you 2 vaccines at the same time, like I was describing that I was being able to do with a hepatitis B vaccine. So without being able to do that, then what would a negative test do? We would just tell you to get the booster anyway. And when 20% of our people have antibodies, but their number of antibody levels are so low, it tells us that we need to boost those up anyway. Remember the slide where if we look at the levels of antibodies that we were seeing, the person with the highest dose of antibodies was still lower than the lowest person in the control group. And so we need to get these people up here, not just have them be positive. And so because of that, that's why I would recommend kind of getting the boosters for everybody and getting the antibody test, probably a month or 2 after the booster, maybe makes some sense to kind of know whether we need to do a 4th dose or something like that. And I think that might be a little bit more reasonable, but at this point, I think we're a little bit limited in kind of saying, what would you do with the test one way or the other? Just get the booster. One of the questions I saw in the chat that I'm going to answer real quick, Kelsey, was this issue around flu shots and getting the flu shot along the booster. And I think it's a great question. The recommendation right now is to try and separate them out some. It probably doesn't matter too much, but it's just if one makes you kind of sickish, you definitely don't want to add to it by having sickish from 2 different things. So trying to kind of spread out the pain, maybe, I guess, makes the most sense. Your immune system can handle more than one virus at a time, but you just don't want to get real sick to either one or the other. So trying to spread them out a little bit makes, I think, a lot of sense.
Excellent. And on the subject of the vaccines, can you just recap the timing that we've suggested both for folks who are immunocompromised and getting a 3rd dose, when they need to time that from their 2nd dose, as well as any DMT timing considerations? We've had a request for just kind of a recap of that.
Yeah, so again, and our recommendations might be a little bit looser. I think what our main point is just to get vaccinated. But if you can do 2 to 4, probably closer to 4 weeks before or after an infusion, just for ease of sake, I think that would be great. And then as far as relationship to prior infection, giving it at least 4 weeks from a prior infection. You want to have the time to kind of be able to respond to that. Second dose, whether or not you give it 2 or 3 months, I think is also reasonable. So if you didn't get your vaccines until a bit later, I think it's completely fine to wait, something closer to 2 to 3 months until after that. So take your time a little bit more with this one. I think we have a little bit more flexibility. You do have some immunity if you got your first vaccine. Don't push off infusions that much, but if you got to push them off by a week or that kind of stuff, that's fine too. But I think this is a little bit less urgent than in the past, simply because if you've done your 2 shots, you already have a decent immune system. And then one question here about sort of being able to get them at the clinic. So at the clinic, we still don't have these vaccines. These vaccines have to be frozen so cold that at the university, we're mostly getting the Pfizer vaccine. The vaccine clinics are getting expanded fairly quickly. And the main ones that are happening are now on Saturdays. And I can tell you, I got my booster this past Saturday. It flows quickly. They're well set up for it. It gives you the weekend to kind of recover from sore arms and things like that. And so they do a great job with them. They're planning to open up some extra ones during the week, but as far as I know, they haven't quite yet.
And we've had a couple of different questions about folks wondering if they received the Moderna before and now they just got a Pfizer booster. Was that okay to mix? Should you be trying to get the same one? What if you've got J&J first?
Yeah, so the general guideline right now is to try and stay with the same type of vaccine. If this is one of those where, again, I think it's a lot of theoretical discussion for this, in the sense that if you switch, it might be able to respond to your immune system, might be able to respond a little bit better. And so trying to switch sometimes might be helpful. On the other hand, if you are trying to boost that response, and if you had sort of a response to the first one, trying to kind of keep it the same so you can kind of keep, sort of bouncing off and leaping off that same platform might make sense. And I think that's kind of the theory that they're kind of subscribing to with it. So again, the guidelines right now are to kind of try and stay. I don't know that it matters a ton, but did that cover it? Was there a second part to that I missed?
The J&J vaccine.
Yeah, the J&J is a little bit in a funny situation because right now a booster for the J&J is not recommended, or it hasn't been so far proposed. So it's in a little bit of a funny place. I suspect that within a couple of weeks, there'll be some guidance to recommend that. Most people in the United States have received the mRNA ones. And so I think that that's where the focus has been, to at least get something out. And whether or not people who have gotten the J&J would switch over and get the mRNA vaccines may be reasonable as well. But again, that's more of my thoughts and less of what's being recommended at this point. Again, they're still trying to kind of catch up with some of these recommendations.
And you mentioned the UC Health vaccine clinics are happening. And I just wanted to state also that community pharmacies like King Soopers, CVS, et cetera, also are doing the 3rd dose. So you can just let them know, self-attest to being immunocompromised in order to sign up. Check their website. Some of them are walk-in only, some of them are appointments, but there are many different options for how you get that 3rd dose.
And that's a great point, Kelsey. I think a lot of times those local pharmacies are taking walk-ins versus university is not. And it's the same type of vaccine. So sometimes it's just easier to kind of get them done locally than having to come up through the university to get them done. And then this issue around, do I qualify or not? it really comes down to you saying I'm immunosuppressed. Even within the university, they don't check what drugs you're on. I'm not trying to say you lie that you're immunosuppressed when you're not, but the reality is that they're kind of really basing this a lot of times on oncology patients and not about MS. If you look at the number of patients with cancer compared to those with MS, it's a much higher number. And so like even the guidance around waiting 6 months until after you're done with rituximab clearly doesn't make a lot of sense for neurology. The meetings I was just having today were around trying to get experience from other people with a little bit more chronic illness on immunosuppression. So talking to people from GI, allergy and immunology, rheumatology, us in neurology, and things like this to kind of come up with a little bit more consensus around that. So again, all you have to do is self-attest to kind of say I'm immunosuppressed, and that's good enough for all this stuff.
Can you talk a little bit about specifically the B cell depleting DMTs and why we're concerned about the vaccine response? We had a couple of different questions wondering, is the protection different if you were fully vaccinated before you started the B cell depleting DMT? And if you have an infusion of Ocrevus or rituximab, does it completely wipe out your B cells so you are then losing any protection you've already gained?
Yeah, so if you got vaccinated before you started treatment, then your immune response is really pretty good. I'm going to go back to this slide because by that point, then these B cells have become plasma cells, and these are not affected by those treatments. So once you have antibodies, these treatments really should not affect the levels of antibodies, except just to say these cells eventually do die. So the natural tendencies for these antibodies, to kind of slowly wane down over time. If you're starting treatment kind of afterwards, then it becomes a little bit more of an issue because then you don't have these cells to become the plasma cells to make those antibodies. At least not in the blood. Again, you do have these cells in lymph nodes and other tissues and things like this. So some of this can still happen. It's just instead of ending up with a lot of plasma cells to make those antibodies, you end up with a lot less.
Do you have any data or any insight you can give on what the MS Center has seen as far as breakthrough cases for MS patients, particularly on B cell therapies, data on the vaccine effectiveness for people with MS, as well as long COVID? Have we seen a lot of long COVID cases, even from these less symptomatic breakthrough cases, and the Delta variant?
Yeah, so let me talk about the long haulers a little bit, just because I didn't touch on that in the presentation, and then I'll come back. We have seen some people get sick and then be sick for a period of time afterwards. And to be honest, I'm not sure that it's any different from the level seen in the general population. There was a study that was presented at the AAN, the American Academy of Neurology, sort of in April, that showed that the main issue around developing long haulers was mostly associated with people who had anxiety and depression prior to the COVID infection. To be honest, the cases that I've mostly seen of kind of longer lasting type symptoms, I think were the people that had bad infection, mostly pneumonias, and ended up with sort of like a bronchitis type picture. So just a lot of coughing and things like this, needing inhalers, people with a little bit of asthma and things like this, where it just then become a really hard time to kind of kick it. It stays in your lungs, it kind of stays there for a really long time, and it's really hard to kind of clear it from there. And so that makes it really tough from that perspective to kind of clear things out. And then what was the second part, Kelsey? There was
long COVID, and then also just kind of general, if there's a difference in breakthrough cases with folks with MS versus not.
Yeah. We've definitely seen breakthrough disease. I was a little bit nervous because about 3 weeks ago, on one day, I think we heard about 3 patients in the clinic that had broken through. 2 were on B cell depleting therapies. One was at Tecfidera. And I gotta be honest, at least the good news for it is that all three ended up with fairly mild disease. So it was holding true to the pattern that we would see breakthrough disease, but that it would be fairly mild in nature. So none of these patients had to go to the hospital, and they all ended up kind of getting back to normal within a few days, a week or two or something like that, at the longest. So I think it's been one of those where we are seeing some breakthrough disease, even on B-cell depleting therapies, but we're still mostly kind of getting milder disease on vaccines. And that's been with Delta. This was just a few weeks ago. So not having to go back to the original kind of variants or, that kind of stuff.
Are we seeing a lot of side effects from the booster, particularly, just side effects from the booster.
Perfect. So, so mostly what I can tell you is my personal experience, because I know that I've had a couple of people get the booster, but since it only really started a couple of weeks ago, not a lot of people have kind of come back to clinic, but at least I'm not getting a ton of people calling into clinics saying that they feel terrible with it. I got to be honest, I got mine on Saturday and my arm swelled up. I feel like I got an egg underneath my skin, so I think it's real. Good response, I guess. I'll take that as the glass half full. Felt a little bit tired, but otherwise doing okay. My wife had Rigers after the second dose. She got her booster on Sunday, and she actually did pretty well without any fevers or chills or anything else like that. So, which I guess reminds me then, if my wife got booster on Sunday, that there's clinics also available on Sunday. So right there, see, I'm already forgetting all the availability at the hospital.
You mentioned that folks should be, taking some precautions and knowing who they're hanging out with and considering their personal risks. Do you have any more that you can say about how to evaluate that risk, and should family and significant others of folks be taking more precautions, wearing more masks in public, particularly if folks are going back to the office and they don't know if their office mates have been vaccinated or not?
Yeah, that one's a little bit hard for me to answer because both at the hospital and through the university, everybody now is being required as of tomorrow to be fully vaccinated. Otherwise, you can't come in. So the general idea that I would think about is, if you don't know, I would mask up. If you trust the people to tell you, hey, I'm sick or something like this, I got an exposure or other things like this, that's the point with friends, where I think it's okay to get together with them and just not, drop the mask, especially since you've been vaccinated, because you're going to have some protection then against the virus. There's a question around air travel. Air travel, you're surrounded, really closely knit with, 200 of your closest friends. And so that would be a perfect setting for, wearing a mask and being careful along those lines. So I think it's partly trying to know how many people you're there, how close you're going to be, are you indoors, outdoors, those kinds of things, in order to kind of decide whether it's okay to drop your mask or not. And so I think it's that kind of stuff. I go to the grocery store, and if I get there early enough and there's hardly anybody there, I don't wear a mask. If there's a lot of people there, then I start to wear a mask. And I think, around coworkers, it's the same thing. If you're doing a job where you're in an office and you're saying in cubicles and people are right next to you and you're not sure if they're vaccinated or not, that might be a time to wear, to wear your mask. I think it's okay to go to work and to do that and be present as part of the group. But maybe be a little bit more careful. If you're in a situation where people have been vaccinated, I would, and then I would feel a little bit more comfortable around saying, like, I'm okay without wearing the mask in that situation.
And then I have two more questions, and then I'll let you go. Thank you for staying a few extra minutes. If someone has had bad reactions to Ocrevus should they be concerned about having a vaccine reaction?
What was the first part? What were the chances of getting a reaction?
Yeah, this person has had bad reactions to Ocrevus with itchy throat, scratchy voice for the whole 3 years that they've been on Ocrevus, and they're wondering if they should be concerned about having vaccine reactions.
I would say absolutely not. I mean, it might happen, but it's completely two different things, right? So in one, most of the reactions with the B cell depleting therapies are not an allergy reaction to the drug. You're responding to the B cells popping loose and releasing chemicals that your body then reacts to. Most of these, again, are these little triangles and signals that are going from cell to cell. And some of these say go, some of them say stop. And when you get both of them, then the system just doesn't know what to do with that. As far as getting a reaction, to some extent, it's kind of a blessing and a curse because it tells you your body's reacting to the vaccine. And it's developing something. And so it's helpful to kind of know that, that something's happening. I got nervous. I believe in vaccines so much. I got my 2 kids into the under 12 vaccines, and there's a 2/3 chance that they would get the vaccine. And to be honest, none of them reacted at all. So I'm a little bit nervous that they both ended up on the sugar pills. Most reactions tend to be pretty minor to the vaccine. And so they're tolerable. Ibuprofen, Tylenol can be really helpful for most of the symptoms associated with the vaccine.
And finally, we did have a couple questions wondering if you would recommend or in what situation you might recommend people consider changing their disease-modifying therapy so that they are not immunocompromised. Is that a thing people should be considering?
Yeah, so remember that we have to look at the risk balance of everything, right? And what's worse, the MS or COVID? And I think to some extent with the vaccines, COVID has become less of an issue than the MS. So having to change a lot of things around COVID is less of a concern. We got to remember, at worst, the B cell therapies might increase the risk of bad outcomes by 3-fold. But again, the vaccines prevent those bad outcomes by a lot, more so than sort of the run-of-the-mill infection. So that with that in mind, I probably wouldn't consider a lot of changes around disease-modifying therapy. Now, if you're at a point where from an MS perspective, you don't need as strong of a medicine as what you're on, then I think it's reasonable to switch out to something else. And a patient who is older, where the number of attacks really kind of comes down, if you're not progressing, where you need some of the B cell depleting therapies, and those kinds of things, I think those patients are very reasonable to kind of switch out to the pills and get the convenience of not having to deal with infusions. Again, for some people that's a convenience, and for some people that's not a convenience. But trying to find what works for you, I think, becomes the most important part.
Awesome. Thank you so much, Dr. Alvarez, for your time. Thank you, everyone who's contributed questions today. Just a reminder, this webinar will be archived on mscenter.org and YouTube tomorrow. So if you missed any information, you need to rehear anything. We did get a couple of repeat questions, so I would encourage folks to watch this again. A lot of the information was complicated, so it might take a time or two of listening through. But thank you, Dr. Alvarez, for sharing with us. And please make sure that folks are signed up for our mailing list in order to receive notifications about upcoming educational programming.
Perfect. I did see one quick question around how long to test after vaccines to look for antibodies. Try to give them at least 4 weeks minimum to probably a good 6 to 8 weeks. That's about as long as it takes to get that to occur. And then the other comment was around, do I need to go back to the same place to get my 3rd COVID booster? And the answer for that is no. You can get them anywhere. Again, the recommendation around staying with the same one, I would say if you're having to hunt around because nobody in your area does Moderna and you got the Pfizer, or sorry, you got Moderna and there's nobody else around you that's doing Moderna anymore, and they're doing Pfizer, just get a Pfizer. But those are the things that I think we have flexibility with. So with that, thank you very much, Kelsey, and we can stop it now.
Awesome. Thank you, guys.